Go ahead, ma'am.
A very good afternoon. I am Dr. Meghana, Clinical Head and Fertility Specialist at HSR Layout Oasis Fertility, Bangalore. Today's topic for discussion is failed IUI. What next? Many couples who are going through fertility treatment go through IUI as one of the first step in the fertility treatment. So when do a couple go for IUI? That is the first thing which we need to know. Than to know what happens if a couple fails this step of IUI, what are the next options available to them. So just as a now beginning, what is IUI? It is intrauterine insemination. This is one of the basic fertility treatments wherein around the time of ovulation, the processed semen sample is introduced into the uterine cavity of the woman using a thin catheter. Here, the point which we need to note is the success rate of IUI per cycle is approximately 16 to 18%. That means if we statistically convert it, roughly 1 in 5 couples going through the fertility treatment conceive per cycle of IUI. That means the remaining 4 out of these 5 couples are facing the diagnosis of having a failed IUI. So, how do they go about? What are the prerequisites before going ahead with IUI? The first thing what we need to see is this couple really a candidate for IUI before even we take them for IUI and they face the dilemma of doing what next after a failed IUI. So the prerequisites before IUI will be a basic infertility workup for the woman, which includes the blood investigations, what we call as reproductive hormones. Then there are other hormones like either the thyroid hormone or the prolactin hormone to see if they are diabetic, hypertensive, anemic. So we need to do these basic investigations, followed by an ultrasound scan to look for the endometrial thickness, to look if there are any abnormalities with the uterus in its shape, size, or there are presence of fibroids, polyps. These are some of the things which we look for in the uterus when we do a baseline scan. Then to look for the ovaries, if there are any cysts, the number of follicles in each ovary and the size of these follicles. A tubal patency test is usually done before an IUI, though it's not an actual prerequisite. There are many conditions where a woman goes through probably 1 or 2 cycles of IUI before a tubal test also. Along with the woman, a basic infertility workup of the man is also required, wherein his routine blood investigations, like in the woman looking for his hemoglobin, thyroid profile, viral markers, all these are looked at, along with the semen analysis. When we look at the semen analysis, there are various reasons why a couple goes through IUI. One of the main reasons could be because of some abnormalities in the semen in the form of either reduced count, motility, or morphology, where we say that the IUI is being done for the male factor infertility. A semen count less than 5 million certainly doesn't give us good results with IUI, or a processed semen count less than 1 million per ml also doesn't give us good results with IUI. So when we look at the parameters, a semen sample count of more than 10 million per ml usually is what gives us a fair enough results with IUI. What's the procedure of IUI? A scan is done on the second or third day of the cycle of the woman to rule out the presence of cysts and to also look for an endometrial thickness. An endometrial thickness less than 5 millimeter and any follicle less than 10 millimeter is a good enough cycle to go ahead with IUI. Then the woman is started either on oral ovulogels or gonadotropins, or usually the woman is started on tablets and the injections are added as and when required. A scan is usually done along the 10th or 11th day to look for follicular growth. Then, depending on the size of the follicle and endometrial thickness, the next few scans are planned such that we look for the endometrium to be at least 8 millimeters in thickness and the largest follicle 18 to 20 millimeters minimum, depending on the kind of medications which have been used. Then, the ovulation trigger is done once the parameters have already been achieved and the woman is planned for IUI 36 to 48 hours, 40 hours later. At times, LH blood test is also done to determine whether already the LH rise has started and we need to plan the IUI a little earlier. Taking care of few of these finer points helps us to get better results. Then on the day the IUI is planned, ultrasound scan is done to look for signs of ovulation on the scan, wherein we look whether the follicle has ruptured, whether there is free fluid in the POD, or changes in the endometrial thickness and pattern. Then the woman goes through IUI, wherein the husband gives the semen sample. The processing of the semen sample takes approximately an hour, and then the procedure of IUI is per se only 2 to 3 minutes. And then the woman lies down for 15 to 20 minutes. The luteal phase support is advised for the next 15 days, at the end of which either a urine pregnancy test or a beta HCG blood test is done to look for the presence of pregnancy. This is the procedure of IUI, but this process has failed. At the end of the 15 days of luteal phase support, the woman does a urine pregnancy test which comes out as negative, or a beta HCG test which is negative. So the next question is, what next? After the procedure has went well, if the pregnancy doesn't happen, then the couple comes and sits in front of us asking what next. So what the process we do is, we do a tubal testing if not done earlier. Tubal testing can be done in various ways, either HSG, wherein the patency of the tubes are looked for under a X-ray guidance. This gives us an objective analysis of whether the tubes are patent, that means the tubes are open, or they are blocked, and if they are blocked, at what level of the tube are they blocked. Sometimes a diagnostic hysterolaparoscopy has to be planned. Could be to rule out stage 1 or stage 2 endometriosis, or during ultrasound scan there is a suspicion of adhesions, or a tubal pathology is suspected during ultrasound scan in the form of thickening in the adnexa or fluid collection in the adnexa where the tubes are situated, or there is a doubt that there could be a reason for tuberculosis. The way we suspect for pelvic tuberculosis is that it could be that they have no symptoms at all, or the signs on ultrasound are negative. The patient might have thin endometrium, or there could be collection of fluid, which could be a suspicion for hydrosalpinx. So during hysterolaparoscopy, we look for any endometriotic spurs to see for stage 1 and stage 2 endometriosis. If there are any adhesions, that means the organs being stuck to one another, then the organs are tried to be separated as much as possible. The tubal patency is checked in the form of CPT, wherein a blue dye called methylene blue dye is passed through the tubes, and then we look for the passage of the dye through the tubes to look for the tubal patency. And along with looking for the patency, we also look the way this dye passes, whether there is a delay in the passage of the dye, whether there are circulations in the tube, that means collection of the dye in the tube before it eventually comes out, leading to us diagnosing it as patent tubes. So these are the things which are looked at during hysterolaparoscopy, which might be missed while doing a HSG or a sonosalpingography. The one of the other tests to do tubal testing is sonosalpingography. Under ultrasound guidance, we look for the presence of fluid in the POD, wherein we can diagnose that the tubes are patent, but it is subjective and we cannot give a film like how we give either with a HSG or with a diagnostic hysterolaparoscopy. As mentioned earlier, tuberculosis has to be ruled out taking sample from the endometrium and testing for tuberculosis, as tuberculosis is the most common disease in India and is one of the most common causes for infertility in India. Then also we need to relook the semen parameters. The semen analysis is always preferable to be done in a fertility center wherein the proper semen analysis has taken place to look for the count, motility and morphology, because many times we miss these parameters. Also, to look for the presence of the pus cells in the semen sample, which can lead to a diagnosis of seminal infection. This itself could be the cause for the decreased motility, leading to subnormal semen parameters, leading to infertility. If one IUI has failed and we find that there are subnormal seminal parameters with mild to moderate male factor infertility, a double IUI can be tried. So, what is double IUI? Double IUI is wherein in a particular cycle, the woman goes through consecutive day IUIs. That is, as mentioned earlier, we give the ovulation trigger based on the endometrial thickness and the size of the follicles. The day the trigger is given, we usually plan for the IUI 36 to 40 hours later in a single IUI. But in a cycle where we are planning to do consecutive day IUI or double IUI, the woman is called the next day after giving the HCG trigger, wherein the follicle might or might not have ruptured and still she goes through the IUI. Then the second day, if the follicle has not ruptured on the first day, she again goes through IUI on the next day. So that is consecutive day IUIs, thereby increasing the chances of the sperm reaching the ovulated follicle and thereby increasing the chances of pregnancy. This is one of the ways in which we can increase the chance of success with IUI in cases where there is subnormal semen parameters in the form of mild to moderate oligoasthenospermia and where multiple follicles have come up which might or might not release at the same time. So these are the things which we have done after one failed IUI. But after having gone through a tubal testing, after having made these changes, the woman probably goes through 2 or 3 more cycles of IUI. Usually we say that if a woman has had at least 3 cycles of IUI which has been properly monitored, IUI done at the right time, and the woman has received a good luteal phase support, and still the pregnancy doesn't occur. So what next? So here, if the woman has gone through only tubal testing in the form of HSG, as I said, HSG can only detect the patency of the tubes. It cannot detect if there is any minor tubal pathology, which could be again a cause for infertility, or if at all only a SST has done, because SSG only says that at least one tube is patent. It is probably very difficult with SSG to know if both the tubes are patent, because here we look for collection of fluid in the pouch of Douglas, and HSG or SSG can still not diagnose the presence of or can treat the presence of adhesions or any other stage 1 or stage 2 endometriosis. So if a woman has failed 3 cycles of IUI with good ovarian reserve and also good semen parameters, then hysterolaparoscopy can be done if at all not done earlier. We again relook for the semen parameters in the form of semen analysis, along with looking for a semen culture sensitivity if it was not done before, and also to look for DNA fragmentation index. So what is DNA fragmentation index? DNA fragmentation index is wherein it's a test done on the semen sample, wherein a semen sample is collected when there is an abstinence period of 48 to 72 hours, to look for the fragmentation in the DFI, in the semen sperms, along with looking for the other parameters like count, motility, and morphology. So the DNA fragmentation at a level indicates if there is any problem with the DNA, thereby reducing the chances of the semen sample giving a pregnancy, or increasing the chances of having a negative report, or could be in the form of early pregnancy losses. So if the DFI is found to be higher than 25%, it is said to be abnormal. Then the male requires medication, or to look for other parameters which could be a reason for raised DFI, probably in the form of varicocele or in the form of lifestyle wherein he might be obese, which could have led to the raised DFI, might be a smoker, which can again raise DFI. So these are some of the things which have to be corrected when the DFI is on the higher side, and then relook for the DFI levels probably 3 months later, and then relook for the feasibility of doing a repeat IUI. If there are any abnormalities like in the form of varicocele, which could be a cause for abnormal semen parameters that have to be corrected, lifestyle changes in both the woman and the female partner also goes a long way in improving their outcome. After all this correction, probably we might want to do one more cycle of IUI. So the cumulative pregnancy rate with 3 cycles of IUI is usually around 60 to 80%, and a couple, if they can conceive with IUI, usually conceives in the first 3 to 4 cycles of IUI. If these 3 to 4 cycles of IUI have not given a pregnancy, then the next step we need to look at is whether we need to do an IVF, or what we do is ICSI in these cases. So what is IVF? And why do we do IVF if they have failed IUI cycles? Why not go on doing IUIs? There are probably couples who have gone through 6, 8, 10 cycles of IUI, and at the end of it, they might have conceived in the 7th, 8th, or 9th cycle of IUI. But the amount of medications which the woman has to take in these 8 to 9 cycles of IUI, along with the number of scans which she needs to do during this time, and the number of injections, the amount of medication she has to take, and every time we need to do an IUI, we need to introduce a catheter into the uterus. And every time we introduce a catheter into the uterus, there is that minimal risk of infection. So these can be avoided, and along with that, 8 to 9 cycles of IUI doesn't come cheap; it does cost. So in the same cost, yes, certainly they can get through an IUI IVF cycle, wherein along with diagnosing what is the problem because of which they could not conceive with IUI, they also get the result. Since the success rate with IUI is only around 18 to 20% per cycle, whereas the success rate per IVF cycle is approximately 60%. So why should we do IVF in these cases? Why not continue to do only IUIs? One is the amount of injections, medications, everything the woman goes through. And again, there could be some undiagnosed tubal pathology in spite of doing HSG and laparoscopy. What we are diagnosing during tubal testing is only the objective analysis of the tubes. That means we see whether the dye is passing through the tube either during a HSG or during a laparoscopy and diagnose it as a patent tube or a blocked tube. But we don't have tests specifically to check for the ciliary functions of the tube or for the microscopic function of the tube. So that is the reason many times, in spite of having patent tubes, women end up having not being able to get pregnant. And also, unlike getting the semen sample and checking it under the microscope easily, to check for the oocytes, the only way is again to keep it under the microscope and check it, which happens only during a IVF cycle and not during an IUI cycle. It could be that there is a undiagnosed oocyte abnormality, which could be the reason for a failed IUI. Probably the woman has unruptured follicle syndrome, which was not properly diagnosed on the scan, or probably the woman has an empty follicle syndrome, which cannot be probably diagnosed either by scans or blood tests during an IUI cycle, or it could be an abnormal oocyte. Also, after the ICSI is done, where ICSI is wherein the egg is mixed with the sperm, incubated for 24 hours, and then we look for the fertilization. Then sometimes we realize that the fertilization has not happened. That means, in spite of the egg and sperm probably being normal, the embryos are not formed. And when once the embryos are formed, we will be able to see whether the embryos are of a good quality or are they abnormal. Is the rate of the growth of the embryos good? Are they slow? Are they fast? Any slow growing or a fast growing embryo is again abnormal, and this could be the reason that there is a implantation failure. It could be either an early implantation failure or a late implantation failure, which could have led to the negative IUI result. So these are the things which will not be able to diagnose on IUI, but which we can diagnose on ICSI. And once we get good embryos, we can go ahead with the embryo transfer, which will increase their chances of achieving a pregnancy. Because in an IVF cycle, there is no role for tubes. So even if at all there could be some undiagnosed tubal pathology, that is taken care of in ICSI cycle, where we do the embryos, that is the formation of the embryos which happens in the tubes in a natural pregnancy happens in the lab, and these embryos are introduced back into the uterus at the right time, that is after synchronizing the endometrium with this grade of the embryo, and then we do the embryo transfer. So this helps to achieve that 60% chance per cycle in ICSI compared to 18 to 20% chance only with IUI. So why do we do a frozen embryo transfer instead of a fresh embryo transfer to improve the chances of pregnancy with IVF? In a fresh embryo transfer, like in an IUI cycle, where in an IUI cycle, to improve the chances, we could have probably given them some tablets to get 2, 3, sometimes multiple follicles, which will increase the estradiol levels. And these increased estradiol levels again will have a negative effect on the implantation. So when we do the frozen embryo transfer, which is almost akin to a natural cycle wherein a one follicle comes up, there is a particular rise in the estradiol level only, which will have a very beneficial effect on the endometrium to help in the implantation. We usually get a better success rate. There are many times where we transfer probably 2 embryos when it is a blastocyst stage. So that will also help to increase the chance of pregnancy in an IVF cycle. Along with that, in a lab, we have the facility to grow the embryo till day 5 instead of only till day 2 or day 3. In a natural cycle, the embryo comes into the endometrium at day 5 stage. Considering the fact that the laboratory facilities are much more advanced than in the previous years, we can take these embryos in the laboratory till day 5, make sure that we get a good blastocyst and transfer this blastocyst into the embryo, into the endometrium, wherein it is ready to hold this embryo and the implantation happens better. So the reason for transferring blastocyst is it becomes akin to a natural cycle. Along with that, there are many women who probably require a little bit luteal phase, extra luteal phase support, that is medicines, to support the growth of these embryos. So during an IVF cycle, there is a better chance of conceiving. So the women are given a few medicines in the form of estrogen, progesterone, aspirin. Then folic acid is certainly added in all the pregnancies expected cycles. Then the woman might require steroids to help her improve her chances of pregnancy, might require low molecular weight heparin, might require HCG support, and whatever. I mean, she might be a hypothyroid where the thyroid supplementation has to be done. When we know that the chances of pregnancy in that cycle are better, we certainly give the a specific luteal phase support, because of which her chances of pregnancy becomes better. So just because a woman has had one failed IUI cycle or two or three failed IUI cycles, it's not the end of their infertility journey. There are still many other treatment modalities which can be done to improve her chances of success and the chances of getting a healthy baby. Thank you. Any questions? Yeah. The question which I can see here is, can I get pregnant after failed IUI? Certainly, yes. It depends on the reason why the couple have gone through an IUI cycle. There are many couples who have conceived even after naturally or with medication even after failed IUI. So the most important thing to know is what was the indication for IUI and why. Then the next thing is, why did this IUI fail? Is there anything we can do, like in the form of testing for tubes, doing additional semen testing? So these are the things which will help us to achieve the pregnancy even after failed IUI cycles. What to do after two failed IUIs? If a couple have had two failed IUIs, again, we need to go back to the basics to see what could be the reason for the failed IUI. Is it because the follicle is not in synchrony with the endometrium? Is it because the semen parameters were not good? Is it because there is any other factor in the form of the woman being obese, whether she's hypothyroid or hyperthyroid, not under control? How is their lifestyle? So all these factors will help us to determine what could be the possible reason for the two failed IUIs, and then correcting those factors and taking the cycle forward. So the next question is, how many attempts before IUI is successful? A woman can achieve a successful pregnancy even with the first IUI. But just because a woman has not conceived in the first cycle of IUI, there is no reason to lose heart. One can always try at least 2 to 3 more cycles of IUI. The cumulative pregnancy rate in IUI cycles, when well done, 3 to 4 cycles, should be approximately 60 to 70%. But again, it is if the first or second cycle of IUI has not worked, and before going into the third or fourth cycle of IUI, we need to reassess the couple, see what next can be done, and then take them for the next cycle of IUI. How many rounds of IUI is normal? As per the guidelines, 3 cycles of IUI is what is recommended. And if the couple have not conceived even after 4 cycles of IUI, probably continuing with the same procedure might not give extra results. And it is better to rethink and plan for the next line of treatment. What is the success rate of second IUI? The rate of success per IUI cycle is around 16 to 18%. So even the second cycle of IUI per cycle, it still retains the same rate of 18% per cycle success. Thank you all.